So when we look at the healthcare industry, you come to CES and we all think gadgetry, gadgetry, gadgetry. What's the next, thing that we can put around our wrists and measure our heart rate? But the realities is the healthcare system, like Dr. Tuxson, screamed from our pulpit here, is that it's in trouble. And it's in trouble, and technology does have possibilities to come in and help. And so this session was put together for that sole purpose, to really talk about how is technology stepping up in places of where there's money. Ultimately, it comes down to money, right? So when there's cost savings, life savings, all of that kind of stuff, when we start looking at that, it's extremely important that we look at technology and say, how can we intercede and maybe prevent some hospital readmissions, all the different things that happen upon discharge, compliance issues, all of that. So I think we put together an amazing group of speakers here. So all I'm going to do right now is introduce our moderator to you, and then he'll take it from there. Dr. Peter Fitzgerald is the director of the Center of Cardiovascular Technology and director of the Cardiovascular Core Analysis Laboratory at Stanford University Medical Center. A personal rival of my school, but we won't go there. But the interesting thing about him and why he was selected is he's not just a physician. He's an entrepreneur, he's an engineer, and he likes to fly fish. So with all of that said, I'm going to open up the conversation to them. Thank you very much.
Thank you, Jill. Ladies and gentlemen, it's a pleasure to be here, and I'm kind of maybe the glue. I'm not sure I'm going to be that effective, but this is the panelists that you want to hear from. What I'd like to just start off and say a couple words about is in my practice in taking care of folks that have heart disease. I'm sort of a plumber. So if one of the vessels that supplies the blood to your heart gets clogged up, we have all sorts of wires and balloons and stents, that sort of thing to go into. But as you begin to take care of patients, especially in the last 20 years, you see a real huge disconnect between what I call the 4 Ps, the providers, the payers, we just had a discussion about that, the physicians, and most importantly, the folks we take care of, the patients. That disconnect has been bothersome to me and to a number of my colleagues over the last decade. I think, personally, technology, the things that you know far more about, and these esteemed folks know far more about than I do, can really coalesce those 4 Ps. We have an issue that's going on in this country starting next year where we're going to be responsible for another 25, 30 million folks, younger folks. But somebody didn't do the math. Because when you divide that influx of patients by the primary care providers, by the internist, they have to spend about another 6 hours per day taking care of patients. That's impossible. So it sounds good in the Beltway. It doesn't implement outside the Beltway. So what are we going to have to do? We're going to have to take care of patients virtually. So we're going to have to take care of patients just like I do now.
Hello, Dr. Fitzgerald.
This is a patient in Tokyo. This is the interpreter. This is a sister in New York, and it's very important to integrate the family into this. I don't need to see that patient right away. About a third of my clinic visits I don't think are necessary. I can do it this way. I can coordinate what the images show, discuss that with the patient, discuss that with the family members, talk about the medications they need to take. I need to see this guy, but I don't need to see him right now until we get coalescence of the information, and that way I think myself and others in my sport can provide effective care. Now, we've seen a number of the handheld technologies, and I'm going to show you another one, which is one that you can see quite a bit. And if I don't get too nervous here, and there's no other cardiologists in the room, they won't see the sinus arrhythmia I have. But it's not so much the electrocardiogram, but it's the other features that we can get by holding on to a case or holding on to a phone, such as cardiac output, such as a plasmographic measurement of what is in my lungs in terms of fluid. And I can get AVO2, which is how oxygenated my blood is. Those may not be very specific and accurate tools, but all taken together, That's how we can follow our patients. I want that information for my heart failure patients. I want heart rate variability. I want cardiac output. I want respiratory rate. I want any incidence or tracking of some of these arrhythmias. That all tells me that the patient, being their own control, is slipping out of their zone. So this is something we're doing at Stanford. It has Stanford on the back of it. It's produced by a company called NeuroSky. And we're testing this on our patients. This is an important handheld continuity once these patients leave the hospital. We need to turn these hospitals back to emergent centers, not urgent centers like they've become. So again, I think there's a huge opportunity here with you folks, of course, with the panelists that are going to talk to us here, between sensors and services. But that coordination, whether it's a cell phone, whether it's a network, whether it's the integration piece into specific entities, PD care or elder care, that has to be coordinated, and that will ultimately, at least in my opinion, help with respect to some of the healthcare costs. 26% of our Medicare patients in this country get reimbursed 30 days after they're discharged. That's a travesty. 50% of our heart failure patients come back in 6 months. Those frequent flyers are the cost problems that we have in healthcare. It's not the technology. It's the implementation of this technology, and that's what I hope we're going to all begin to get smart about. And then once you have that, you have an awful lot of big data at the end of this. Imagine a whole millions and millions of patients taking data in their chronic disease issue. We have epidemiologic data. We begin to get patient-specific medications that you can back in a post hoc analysis, see what's best for them. And then finally, for drug trials, we do a horrible job with drug trials now. We need to really treat patient-specific entities for those patient-specific therapies. So I'm going to start off and just ask Jason, who I've followed their technology from some of the digital wireless scales all the way to the digital glucometers and various front-end sensors implementing into chronic disease. And ask Jason how he thinks that we're going to be able to make an impact on healthcare with some of these technologies that you service.
Yeah, sure. It's wonderful to be here again. Appreciate being here on a panel with many folks that we do and we work with every day. I think, to your point, Peter, some of the things you mentioned in the opening, the most important pieces of all this is how they work together effectively. We have a long-standing history in the space. We've been leveraging technology for well over a decade, probably one of the foremost leaders in delivering real-time health information. But technology is one component. I mean, the title of our talk is, Can Technology Rescue the Health Industry? I would say that's a piece of the puzzle, a critical piece of the puzzle. We deliver a lot of innovative sensors, medical devices that communicate information in real time. But the piece and how it works is the service in managing the information on top. It's the implementation, if you will, of that data. What do we do with all this information? We have a lot of powerful tools today to create an environment of all this information. Information is only useful if it's relevant, timely, and managed in a way so that we can act on it, actionable data. And how that works is how we operationalize it. And essentially, we are in the business of bridging that information gap between care providers and health consumers. If it's family members looking after loved ones in a caregiving capacity, or healthcare professionals, you'll hear from Bonnie soon, using that information a different way. We have a unique, growing care network for each individual patient or health consumer. The most exciting part of that is how we can better deliver the right information to all those individuals together to deliver an environment where, the industry is slowly moving towards aligning financial incentives to quality. But the real piece is integrated, coordinated care environments. and how we leverage that. To family members, utilizing them as an asset to better manage and engage individuals towards their own health management, but also delivering the right information to you as a skilled professional that might be very different than what I might need as a father of a number of children that are going to school, maybe taking readings, et cetera. So it's quite an exciting time with the proliferation of all these new technologies, and you should definitely come see a lot of the fitness technologies, a lot of the sensors and the digital health section. But it's really, how do we operationalize that, deliver those solutions as appropriate to people with issues in weight versus congestive heart failure.
And of course, it's becoming an issue. I think the only shelf that I saw that was completely naked in multiple stores throughout at least my limited Christmas shopping was the Fitbits, right? There was nothing, you couldn't buy anything, right? They were all taken over. So people have become much more conscious about, whether it's a Nike Fuel Band or whether it's a Fitbit. If sliding that personal fitness into what I think is going to be very helpful for chronic disease management, whether there's diabetes, whether it's heart failure, whether it's orthopedics, whether it's obesity, whether it's post-stroke. That's going to be, I think, an important issue. But don't these sensors and don't the integration of these sensors depend upon what group you're trying to service?
Well, that's the most important part. I mean, you think of the population in a pyramid, and on the bottom you have the living well, those that are actively immersed in their own health, those that probably don't need a lot of technologies to service their own health because they're quite aware of their well-being. Then you start moving up the chain. Of course, you move up the chain in the cost of the healthcare system. Sure. Those with one or ultimately many chronic conditions, and then that top pyramid, the frequent flyers and the sickest of the sick. And where most of the time, fitness applications, those free or $1.05 applications, are not as meaningful ultimately to the healthcare system, in where we can save dollars and more meaningfully engage patients that actually need the assistance. And that's why I mentioned, can technology rescue the health industry? It's really about the integrated, coordinated care environments that we connect better to deliver that service. And that's where it makes a lot of sense. It's the service level on top, leveraging the right tools, right technologies to deliver that.
So the only thing I would caution you to is just don't give me more stuff. Don't give me more emails. Don't give me more data. Don't let me sift through it, because A, I'm not going to get paid more for it, and B, I'm going to get frustrated. We've seen all the technologies that puts the doctor in charge of handling these technologies. They don't know what they're doing. I mean, their 13-year-old might. But the docs like me, they can't handle all this information. So we need to also make it serviceable to that point person or that point group, because I don't want 100 more emails. So we're going to have to think about that. Charles, you're sort of an icon in the space. You've been doing it for a long time. You sort of have narrowed into, the respect of the elder, which is incredibly important and obviously a huge tenor to where our healthcare costs go. Can you talk a little bit about the integration to that specific model?
Sure. Thank you, Peter. Happy to be here. It's hard to talk about saving money in healthcare without talking about aging, given the high percentage of healthcare costs that come in your later years. But what I really came here to talk about is ignorance. As we saw in our recent political theater in this country, ignorance can somehow be comforting. It's often comforting. In fact, I've heard it's bliss. And when it comes to, say, a spousal assessment of one's derriere, ignorance is a good thing. But in healthcare and wellness, ignorance is a very, very bad strategy. And when we start with the healthcare professional, I'm always stunned by the fact that someone's in a Hillman bed and the doctor knows everything about them whenever they turn. Is omniscient. 2 days later, they're pulling into their driveway. That doctor is now blind. It's a tremendous gap in information. But I think even more important is the patient. For days, the patient has been told exactly what to do, when to eat, when to take meds, when to sleep. Once again, they're now back home. And often that ignorance is not intentional. They would like to be informed about their health care and their recovery. So I think that the great savings in healthcare will become on the patient side. We don't need smarter doctors. We don't need smarter devices or MRIs. We need smarter patients. Not smarter, more informed, more knowledgeable patients. Because you come home, you've had 5 minutes of a discharged person talking to you. This is an 82-year-old wife and an 85-year-old husband who's just been there, and they get home and they're lost. And it's not surprising they come back in 2 months. So I think that's where technology in the home, having videos, and that discharged person should actually just tape their advice so it can be played over and over again when you're back home. And this is true of chronic condition and general long-term care. So I think that's where the big bang is going to be. We talk about taxation. It's fun to tax the super rich, but actually, that doesn't really bring in much money. You need to tax where the numbers are, and that's the great middle class. We need to influence where the great numbers are, and that's the patient.
And it's not that difficult because, when I sit there and I've got the patient and the brother or the wife on the phone, it's amazing the conversations you have. No. It's the green pill that you take at night. No. It's the blue pill that I take in the morning. Fundamental explanations can really make a big, big difference. So that communication and all those things are stored basically on the patient's computer so they can go back and review that conversation, review what was talked about with the medications. We're going to see insurance companies, and we've already seen an announcement last week of WellPoint going to cover the virtual patient visit, at least in Oregon and California. So that's going to be something that we're going to learn over time. Now, I also want to just point out about Charles. Charles talks about the ignorant healthcare provider. I think he's talking about me. Now, he lives in Green Bay, and I live in San Francisco, and there's a game this weekend, so that's kind of why he's picking on me a little bit. Bonnie, you have an interesting sort of a bird's eye view of how to coalesce healthcare systems. And so as you can do that, because we're very fragmented throughout the country. There's some places in the world, Switzerland, actually Taiwan's got a great coalescence of healthcare, but not in the United States. But you have in northern part of Northern Carolina, I believe it is, a coalescence of hospitals. What have you learned by applying that technology to somewhat of a homogeneous type of care environment? Are you saving money? Are patients doing better?
To me?
I'm sure.
Yeah, okay. Yes, I'm very glad to be here. I'm one of the few up here and in the next 2 days that really is someone who has implemented programs that used technology in patients' homes. And I can say, yes, technology is an absolutely critical component to helping elderly patients and chronic disease patients stay home. But it's just one part of it. I think that way too many times we focus way too much on the technology and not on the services that you have to wrap around the technology. Something you just said about ignorance and patients, and what I've found over and over again is that there are very few patients that don't want to learn what to do. Right. But the majority of the patients don't want you to tell them what they have to do. That's right. They want you to engage them. They want you to help them understand why this works. In my experience, I've been in this space for 15 years, and I've now coined it to the following: see, feel, change. With this technology, every single day the patient's collecting their data. They can see that data. They then will receive a phone call from a registered nurse who says, Mrs. Jones, I see your weight's up today, and I see your blood pressure's up today. Tell me how you feel. And then that patient will tell you how they feel. And then that nurse helps that patient make that correlation between what they did and how they feel. And that's a very powerful way to make someone want to change. All of us as healthcare providers and everyone in this room knows that if you have heart failure, you do not need you need to limit your sodium intake. We tell patients when they're discharged from the hospital with heart failure, you cannot eat Chinese, you can't do this, you can't do that, you can't do this. Well, patients come home and what do they do with that information? They put it aside because it's too much information of what you can't do. With this, the patient, my mother, she's be 91 in March. She's been on this technology since 2006. History of heart failure, history of cardiovascular disease. She has had no readmissions or heart failure or ER visits since 2006 because now she has made the correlation between if I eat Chinese food, this is how I feel, and that motivates me to change. So this isn't rocket science. It really is more about and let me see my data every day. Let me associate how I feel to that data and then motivate me to change. Our healthcare system in Eastern North Carolina, we have one flagship hospital, tertiary care medical center, and 8 other rural hospitals. We have indeed implemented this telehealth February 1st of last year. To date, we have enrolled a little over 1,300 patients. Our refusal rate is less than 10% from those patients, and I wanted to share you some of our initial results. We monitor our patients anywhere from 30 to 90 days. We pull the data on patients from 3 months prior to them being admitted on the program, after they come off the program, and then we wait 3 months after discharge to pull data. So it's slow in getting the data, but for the first 118 patients, 99 of those patients experienced hospitalizations. Those 99 patients experienced 155 hospitalizations 3 months prior to telehealth. While they were on telehealth, there were only 33 hospital admissions. And then the 3 months after discharge, there were only 50 hospitalizations. What does that demonstrate to you? The patient has made a change. They have understood what they're doing. They understand what they need to do. Bed days prior to telehealth were 763 bed days. That's for 99 patients. During telehealth, 136 bed days, and 3 months following telehealth, only 175 bed days. What did the charges change from? Prior were $4.311 million. During telehealth, hospital charges were $702,000. And the 3 months after telehealth, only $1.18 million. This is huge. These are huge dollar amounts. And what we have found that there's lots of layers of telehealth, from care transitions when a patient's identified, the high risk patients in the hospital, monitoring them after they get out of the hospital, to primary care providers and specialists identifying patients in their practice who need chronic disease management or more over 6 months. We also have seen employee wellness, where companies are now putting kiosks into their companies to monitor their employees.
Yeah, Bonnie, that's great. I think if you ask a CEO of a hospital, and I'm sure there's some here, what they hate the most, it's 3 things. It's blood transfusions, it's in-hospital infections, and it's repeat hospitalizations. If you can decrease that repeat hospitalizations, that's going to have one of the biggest impact. And it is amazing how often we have these frequent flyers. And we don't, as physicians, and I'm to blame here, and other folks are to blame, we don't involve patients in their care. And they want to. Why? Because I walk in, I'm seeing 20 patients in 3 hours, and I tell them what to do. That is the wrong thing to do, and finally, we're beginning to understand it. Now, she's got an advantage because she's got a coalescence of some hospitals that has some unanimity. Now, some of the HMOs have that, and we're seeing some of the insurance companies buy hospitals, which is going to be an important element. But this is all bubbling up, and it's hard to make all that coalescence between those 4 Ps occur with or without technology. Kian, you've done a lot of this for a while, and we haven't necessarily in the last 20 years seen this technology move the dial. Where is the lesion in that process?
Well, to answer the questions, first, great to be here. Jumping to the answer, I think technology is necessary but not sufficient. So there's all these other factors. The other point I'd like to make is we all talk about patients. In our world, and to echo what Charles is saying, it really is about the person. So how we pay the players in our system promotes patients and promotes transactional care, which we heard Dr. Tuxen talk about, is really not the way we're going to get saved. So the way we're going to get saved is the continuity of care when you're in your home, with technology in the home, but also really with the empowerment of the consumer and the person. So how do you make that happen? I can't imagine how you're going to fix this system, frankly, because to me it's 2 words, actually, and it's not political: term limits. Because it's very clear how you need to fix the system. Pay hospitals differently, pay doctors differently. You're going out of your way to do incredible adaptation of technology to help your patients. But that's really your personal initiative. I don't think there's incentives for doctors to do that. As soon as you put a little bit of incentives, there's more and more people adopting. So to me, the answer is really simple. The $1 trillion of waste that we're talking about is $1 trillion of profitability within the system. We talk about cutting costs. Somebody's making money off of that cost. So what we chose to do early on is to look at where there's huge pain, as Charles said, which is the elderly. Everyone is lined up from an economic standpoint to keep their loved ones home or in a facility safe and sound for as long as possible. We need technology. In fact, we partner with our friends here at Ideal Life because you can't do it without technology because otherwise the cost is high. But you also have to have process, and you have to include the alignment of the players. And there's a whole sort of healthcare system outside of our system having to do with home care, with senior living facilities, insurance companies now stepping up, understanding how you can collect this data and improve the lives of folks, and really bending that cost curve.
So who pays for it, though?
Well, the beauty
What's the business model?
The beauty and the problem actually is that that part of healthcare is actually real healthcare because people are paying for it. That's where you see the advertisements on reverse mortgages, on equity lines, on family savings, and they're going to try to keep someone where they are instead of the next stage of care for even an extra month. So the only place in healthcare, well, it's not the only place, there's 3 other places. PERS is another place where it's out of pocket, elective surgery, and concierge doctors. But long-term care as it relates to home care, senior living, which is independent living, and assisted living, is where people are paying out of pocket.
Absolutely.
And
I
if
think,
you,
sorry.
Go ahead.
I was just going to say, and that's one very strong, emerging, and exciting area is the consumer empowerment and taking ownership of one's own care, fiscal responsibility to the one. But I think maybe, Bonnie, you can probably talk this better than I can as far as new alignment in financial incentives around quality or payment towards quality, and we really are getting there. I mean, you have a lot of exciting seismic changes happening in healthcare today more than ever before, even in the last few months, because of a building momentum of what's been going on politically, for right or for wrong. There are a lot of things we could do a little better, but the train has left the station. There's a reinvention among insurers. They don't have the same landlock monopolies they had before. You have more groups incentivized to now think collaboratively and work together. Integrated care models. So it's not just the Kaiser-like models you're having, groups that aren't legally binding entities now working together. And again, you can probably speak to this better than I can.
Absolutely. Being in the space for so long, hospitals forever have not been interested in telehealth because it decreased readmissions and it decreased the amount of money that they made. Now with the HealthCare Affordability Act, and they're going to have penalties on those readmissions, that has shifted their view of that. In addition to that, they know that they're going to be paid in the future on quality.
That's right.
And they have to implement programs that are going to increase the quality scores for their organizations or health systems, or they're going to be, they're going to lose their competitive edge.
Plus, don't forget the fourth thing that I didn't talk about that a CEO of a hospital likes is a little PR about how they have
Absolutely.
less hospitalization and this extended care once they leave, a tentacle of care once they leave the hospital. You know, we get some branding out of this, and I think that's an important issue.
But that doesn't pay the bills enough, I think.
That's right.
And I think the most important thing that we should all appreciate here is something that Bonnie said. For the first time ever, hospitals are going to be financially penalized for people coming back into the hospital.
Oh, what's 1% this year? It'll be 2% next year.
And then they get bonuses. So they get
Based
more
on-
money
sure.
if they're on the top rung of that quality spectrum. So what do I do with that? I can't hire a dozen more healthcare practitioners to go to homes and go visit patients. I need technology. I need scalable technology that I can deliver to patients that work out of the box.
So Jason, I'll push on you a little bit that it doesn't pay the bills. If I increase my admissions by 10 or 15%, that pays the bills from a hospital perspective.
Not enough, right. So it doesn't pay the bills enough, but now you can free up your beds to take care of patients in the right way.
Well, we need to change that hospital to an emergent process rather than an urgent issue, which is a lot of the inefficiency. Now, I have a problem I think medicine is going to change to the 3 Cs. It's going to be capitated cost. We have a fee-for-service that is antiquated, it is going to be consumer-based. Consumers are going to take over because they're going to want their care. And obviously, it'll be done through some of these technologies. But we have a little bit of an impediment here, and it's 3 syllables. You had 2. It's the FDA. They don't allow. Data goes to hospitals and MDs. Doesn't necessarily go to the patients. We need to change that, Charles.
I obviously agree with the incentives, and it looks like we're heading in the right direction. But we don't need more expensive technology. We need some affordable technology. But when you have artificial impediments, compliance issues that prevent someone who's trying to bring something, inexpensive into someone's home that would help them, and all of a sudden they say, no, it must be this medical grade, we have to dip it and sanitize it, and you go, all of a sudden a $400 computer becomes a $2,000 computer. Well, that's a big difference to people. So we have to look at everything else in consumer electronics drops in price. And somehow, anything having to do with healthcare just keeps on going up. And
But
I
don't think that's regulatory. I mean, to defend the FDA a little bit, they don't have a lot of resources to deal with things, but it's not to say that things shouldn't be regulated to some degree. I think it's
of course
right.
they
I
should,
think it's,
but some of it is outrageous.
I've been on the panel at the FDA for 15 years, so
Yeah.
I live and breathe what the folks have been doing there, and they are just trying to get their arms wrapped around.
they're trying to figure it out.
They're trying to figure it out,
Yeah.
and I agree with that. But I tell you, when you start getting outside the United States, and I'd like to at least have somebody's comments about that, my goodness, there's an adoption that's happening in Asia, and a government that's behind this sort of remote monitoring, whether it's in Chennai or whether it's in Canton, that is going to be focused on the value segment, the tier 2 and tier 3, not the POP, pay out of pocket, tier 1. So any ideas on how this helps us globally take care of patients? I realize Cincinnati's important, but
the point about global and FDA, if you combine the two, the costs that go up because of the FDA, as well-intentioned as they must be, really take you out of the global market. And now a lot of companies are actually going globally first and proving things because it's less costly and a lot easier to go through the paperwork.
But I don't think that's regulatory. It's the reluctance of the manufacturers to reduce their margins. It really is. I mean, we're all regulated.
Yeah.
We had to go through the FDA, rightfully so. But it's all about thinking about the consumer. There are models today where this works. You don't have to wait for reimbursement. You should work within what's given and not wait for things. There are opportunities today where we can make these technologies affordable, which we are doing, no question, and scalable to allow access to happen. I think it's a reluctance in the traditional model, which is why you see a lot of wonderful, exciting emerging companies, just out of this room. It's a real exciting time.
Jason, I think it's a little different too. If you get sick and you want to get that image from that hospital and those medical records from that hospital and you want to somehow get them to there, good luck. You're driving back and forth between the hospitals.
That's another question. That's about standardization.
But also practically, Jason, you have a closed system. You control your components. And you have your hardware and you have your software on top of that. To leverage that iPhone or the iPad or the Samsung tablet, in that environment, software can't go to the FDA. So that creates a huge burden on software companies.
We actually have an open platform, and it's more the reluctance of sharing of information. You can probably talk about this.
Absolutely talk about it.
If you have a Samsung tablet, you change a component in it, that has to go through the FDA approval process. There's no need for that to go through the FDA approval. You just change a little chip, and the manufacturer is saying it's doing the same thing. That just increases cost, and it creates uncertainty. You have VCs not investing in device companies going to the FDA. Unlike you, they get stuck, and they may not get approved, the uncertainty. So I agree with you more.
The only thing I'd like to mention that, one of the loopholes, we just heard this wrapped under the Obamacare medical device tax, right? So if I'm a manufacturer of a stent and it goes in, there's a 2.3% tax on not profits, but revenues across the board, even down to the small startup companies. When you go to the consumer, it's not taxed, which is an interesting alignment and potential support of what you're saying, and I think that's an important.
And that's the point. I mean, it's not easy to navigate the playing field, and I think that's what you're working towards. But if we work together, there are a lot of great opportunities today and there are a lot of changes happening for grander opportunities, you know, in the near future. But there are a lot of things we can do today. We are doing today a lot of great savings in healthcare, and I think we're also seeing with this new integrated, coordinated care shift, we're seeing a lot of patients that felt alone in the past that now see there are people that can actually help them.
Bonnie, patient safety, security issues, HIPAA issues, and how do you deal with that?
Patient security issues?
Patients' data security,
Oh.
HIPAA compliance, all that sort of thing.
Okay, one of the things is the software that we use, it's on a cloud server, and there are layers of security to be able to access that. So we haven't had issues from that perspective. Our biggest barrier that we've faced is being able to integrate the EHR and the telehealth vendors'
Right.
data so that one flows to the other and it populates, and it's just not happening. And it's not so much on the telehealth vendor side as it is the EHR vendor side. They are making the decisions, we don't want to do this, this is who we're going to work with, and that is going to, in the future, create many issues. The previous presenter was talking about the data being integrated and flowing everywhere. That's not happening because we're allowing companies to say, we're not going to do that. And that's something that as an industry we have got to focus on and to make sure that happens, because I mean, you look at the meaningful use standards, and I don't mean to be ugly, but I mean, the meaningful use for this year is print out a piece of paper and give it to a patient. Well, is that meaningful?
Right.
No, it's not meaningful for the patient. What would be more meaningful is for their data to be able to be accessed wherever they are in the system. So
And
if they
that's
go to a
what you were talking about,
cardiologist,
Peter, I think.
That's the issue.
they can see it.
That's a frustrating issue, not to the patient. It's frustrating to me. I get
so
faxed an
difficult.
EKG there, and I get faxed a bunch of hospital discharge there. It is incredibly inefficient.
And one of the things that I didn't mention earlier that is very unique about our program is we, not unique is that registered nurses monitor it, but what is unique is if that provider has an electronic health record, they give us access to that. So all of our communication is done through the EHR in a note to that primary care provider or specialist, and then it's up to that provider or specialist to determine if you need to have a medical intervention.
Right.
And that's what decreases the exacerbation
Absolutely.
of the heart failure and other conditions.
And that is not technology contributing to healthcare, which some people in the Beltway think.
Correct.
This is technology facilitating and augmenting patient care and saving dollars. So the data, some of the data that you have is going to be very important to actually shuttle to some of the decision makers so we can get these, granular appreciation of what it means and what it saves.
Well, and I think one thing, CMS right now is just coming out with grants on transition to care.
Right.
Well, that's wonderful. Those programs are great, but they're not scalable. The ratio is 1 to 25 to 30 patients. The ratio of a telehealth program is 1 to 80 to 100 to
Very
120
scalable.
patients.
That's right.
So you can scale these programs and make great impact without incurring.
But getting a pilot within your environment, showing granularity, and then scaling
That- absolutely.
is Charles, you're shaking your head. Do you disagree with us?
I don't disagree. I just, on the privacy issue, I know it's always put up often as a reason to not do something. Oh, privacy. But what is the real problem? I mean, when you really get down to it, what is the problem with privacy on someone's health records? Pre-existing conditions. They don't want someone to know about it, whether it's an employer or, more important, a health insurer. That kind of going away with affordable health. So I think we'll see a huge change in that. Most people are happy to share. It's a joke that seniors like to share too much about their health condition. I mean, my children tell me that to me. So we don't really care that much, Dad. I know what my blood pressure was? No. But if we have that more, and it's a people and process problem, if we have that more, it's not a technology problem. If we have that sharing and a more open look at it and get reasonable about the expectation of privacy, I think we go a long ways.
And go after the ones that are the big cost savings issues. Heart failure, diabetes, blood pressure. I mean, those are 65, 70% of all the healthcare issues. And I think making an impact on those, they're a fairly unique consumer a moiety that you can actually follow. And having that information about these patients over time is going to be very important as well.
Absolutely.
Okay. Good.
I mean, just we're inside the healthcare system in this conversation, which is critical because technology is applying and the changes in the rules and the payment systems are great. I think if we look at also back to the elder care portion for Charlie and I, if you look at where the costs are and when the demographic costs are and where they're going and where Colin talked about from iRobot, where you have to have technology apply here, it's not actually falls, it's not medication adherence, it's not even chronic disease management. The number one issue for the elderly is social isolation.
Yep.
Nobody gets paid on it. There's no insurance payment on it, there's no CMS code on it. Therefore, there's no technology around that, except it's readily available. Use a TV now, you can have somebody talk to people. It changes a single broadcasting medium into a portal to social engagement. That's technology, in my opinion, that's necessary but not sufficient. Everything else around that, but that's where you can get some low-hanging.
Well, we've all seen it.
Yeah, I was just going to say, and that's very, very much the most exciting part, where there are seismic changes with healthcare with regards to payment, but consumers are really empowered now. We recently announced a very exciting partnership with ADT. They do a lot of commercial stuff, but they also are trusted deployers of consumer services and security. Now they have the opportunity with our partnership to also deliver healthcare services.
And that's where it's
quite
going.
exciting.
That's where it's going.
Yeah. And it doesn't take long to see your 75 or 80-year-old folks that the minute you take them out of stimulation, they go downhill.
Yep.
So this sort of interaction, socialization, is a key component to some of the elder care. It's important. You don't believe that. See, he's going after the football game again. Why are you shaking your head, Charles?
No, I completely agree. I shake my head over sometimes the artificial barriers we throw up for
Right.
ourselves.
To ourselves.
That are just, I mean, everyone knows it. Most people know it in this room, but somehow, sorry once again, when you start talking with someone from the FDA, you think you're talking to someone who has never actually had a grandmother.
Right.
Really? I'm
The
sorry.
reviewers are 23 years old. That's right. That's absolutely right.
I think they're from a...
Hey, listen, I think some of the panelists will stay up here after the session if Jill lets us do that, and maybe you can interact with them. I think in the meantime, thank you very much for your attention, and have a good lunch.